Thank you. So I hope you're feeling a little bit better because we've got a fantastic session this afternoon, but it is quite dense. And I'm going to introduce now the moderator for the next session on malaria. Prevention is better than cure. So our moderator for this session is Sashveen Singh. Sashveen is the Tropical Infectious Diseases Advisor for MSF France. She is a Master's in Public Health and Tropical Medicine, and a background in general practice, pediatric and adult emergency medicine. Sashveen is co-lead of MSF's Intersectional Malaria Vaccines Group. And when not working on malaria, she is OCP's Neglected Tropical Diseases Advisor and on the OCP's Epidemics team. Over to you, Sashveen.
Thanks so much, Joanna. And hello and welcome to everybody to the Paediatric Days 2022 session focusing on malaria. I'm very honoured to be asked to help moderate this session. So this session really aims to underline that prevention is better than a cure. So while acknowledging that prevention implementations can sometimes seem more challenging than providing well-known treatment options, over the course of this session, we're going to actually steer the discussion around the debate about these implementation challenges and really focus our attention on some quite efficient implementation strategies that will be able to consider the contextual and some of the seasonal variations that we see across MSF settings and different project locations. So we will provide some quite concrete field-based examples of vector control, intermittent preventive therapy in infants, or as it's known now as perennial malaria chemo prevention, and also SMC, which we've just heard about earlier in the day. So why do we need to be having this conversation today? The most recent WHO malaria report showed us from 2021 that there were actually 241 million cases of malaria that were recorded in 2020, and of which 627,000 were fatal. 95% of these cases and 96% of all deaths, sadly, were in the African region, and about 80% were actually in kids under 5. And four countries actually account for the majority of the deaths. And you can see on the slide here, Nigeria, DRC, Tanzania, and Mozambique. They're all places where MSF have a presence. And you can see from this graph that the trends in absolute numbers of malaria cases, but as well as deaths, have seemed to be plateauing over the last years. And despite current tools that we have for prevention, some high burden countries are actually even seeing an increase. 32 countries showed an increased case incidence, and 17 countries had an increase of 40% or more. That was just in 2020 when we compared to 2015 levels. The reasons behind this are a bit complex. So in sub-Saharan Africa, more and more people are living in malaria risk areas. Malaria funding has also been plateauing, sadly, and essential vector control interventions have been flattening in some places. So for many people living in risk areas, they also have trouble accessing emergency and primary health care. It's just not adequate. So we need to do something about this. Now, the use of long-lasting insecticide nets are already embedded in MSF interventions and has the potential to reduce malaria cases by 50% if they're properly distributed and used. But the distribution of nets just cannot happen in a vacuum. It has to be part of a broader package of malaria interventions. Strategies such as the implementation of IPTI, or SMC, IPTI can be massively impactful. And actually there's studies looking at IPTI, or intermittent preventive therapy in infants, using a drug called SP, or Fansidar, has shown to significantly reduce clinical malaria and the incidence of anemia in the first year of life, as well as hospital admissions with malaria infection and related to any cause. And recent studies have led to the WHO extending their guideline on IPTI recently to include children up to the age of 2 years. And this has triggered a name change. So this is now called PMC, or perennial malaria chemo prevention. And if we can widely adopt this and implement in recommended areas, it could prevent about 6 million cases of malaria and save tens of thousands of lives. Now, of course, there are new things on the horizon. Vaccines we'll hear about a bit later, which will be an important addition to our toolbox. But actually, our existing tools are not adequately implemented. So we have vector control interventions, we have chemo preventive drugs, we have rapid tests and essential treatments. And in the near future, we will be adding vaccines. But right now, at the global level, malaria control is at a crossroads. So these tools, as I mentioned, are not adequately implemented. So despite gains since 2000 on some indicators, we know that bed nets are not adequately protecting, because we've seen a decline in many places since 2017. We're also seeing less populations who are covered by the protection of indoor residual spraying. We know that not enough pregnant women are getting the Fansidar in the second and third trimester, and clearly this is having impacts on the neonates. And we're also seeing challenges with just the general planning and logistics and implementation of SMC. And if we add to this other threats, then it's really important that we take advantage of this additional impact. Additional focus on malaria in recent years. The WHO had a World Malaria Day this year, and I thought it was interesting to share with you that the theme this year was harness innovation and reduce the malaria disease burden and save lives. And this is a really timely reminder to us that we need to really strengthen all of our interventions. We need to be creative and we need to be proactive in order to tailor our interventions to the local needs. No single tool is going to be able to control malaria alone. Now, let's zoom in to MSF activities. So in MSF, in 2021, we treated 2,681,464 cases, which is enormous. And we've managed malaria campaigns for prevention in very diverse settings, such as Venezuela, Nigeria, Burundi, and Guinea. Sadly, in 2021, just two countries, the DRC and CAR, accounted for more than 50% of all cases of malaria that were treated by MSF. And these are the areas that have had very limited chemo prevention options in the past. But today we're going to hear from MSF teams who are doing some innovative work in those countries to address this. MSF has always been at the forefront of pushing delivery of malaria interventions to those in need. This ranged from implementing RDTs early on, making the switch to artesunate and ACTs, and also the piloting some of the biggest early pilots in SMC in West Africa just a decade ago. And as I mentioned previously, this renewed attention to malaria recently gives us the opportunity to engage more strongly on prevention. MSF have committed to harnessing this momentum in order to improve malaria implementation overall. During this session, we are going to hear from two external speakers. The first, Dr. Kike Sabat, who will be giving us an overview of malaria in children and sharing some challenges. And then Dr. Paul Sondo will be sharing his team's integrated approach of malaria and nutrition. And we'll also hear two very strong voices from the field, two MSF projects working hard on malaria prevention. Before we get started, I just wanted to remind you of the functionality of the platform. Most of you should have been in the session earlier, but just remember the chat, it's actually only for chat. So please don't put your questions in there, otherwise they won't make it to speakers for the end when we start doing questions. But if you do have specific questions, please use the Q&A. You'll see it as a tab on the right-hand side. Now, in order to prepare our minds, we are going to get thinking about malaria and kickstart this session with a short interactive activity. It's an online live poll. If you haven't done one of these already, you'll see on the right-hand side of your screen a tab called Poll, which you can click now. Okay, with we've already gone through a few of these things, so I hope you guys were listening in the intro. The first question is, how many cases of malaria did MSF treat in 2021? Was it between 1 to 1.5 million, 1.5 to 2 million, 2 to 2.5 million, or 2.5 to 3 million? Okay, now hopefully you've got the next question up on your screens. What does the term IPTI stand for? It's now known as perennial malaria chemoprevention. Is it intermittent prophylactic treatment ideal? Identification preventive treatment infants? Intermittent preventive treatment infants? And the third question, how often can you wash a mosquito net? Is it each month? Is it any time I need to do it because it's dirty? Is it never? Okay, and for the final question, what malaria prevention activities have you seen implemented in project locations? Now, please note for this question, you can select all that apply. There is no wrong answer here. This is really just to have an understanding about the different types of interventions that you guys are seeing in your settings. Okay. So thanks so much for participating in that nice activity. Hope you enjoyed that one. It is my next task here is really to introduce our first speaker. So it is my great pleasure to introduce to you Dr. Kiki Basat. So Dr. Kiki is a medical doctor. He specialised in paediatrics from Barcelona in 2004 and also has qualifications in tropical medicine since 2004 from the University of Barcelona. He also has qualifications in clinical epidemiology from the London School of Tropical Medicine and Hygiene, which he completed in 2008. Later on, he completed a PhD in medical sciences in 2009 at the University of Barcelona with his thesis entitled Malaria in the Paediatric Wards of a Rural Mozambican Hospital and the Clinical Development of New Antimalarial Drugs. He is also a research professor for ICREA, which is the Catalan Institution for Research and Advanced Studies. He is the head of the malaria program at IS Global. in Barcelona, and also a practicing paediatrician with special interest in infectious disease epidemiology and public health. Dr. Bassat has attempted to combine all his clinical work with biomedical research in those diseases that most affect the poor and vulnerable. His main area of interest has been the prevention and treatment of malaria in childhood, with a particular focus on understanding the clinical overlap of malaria and the other common paediatric conditions, and the use of biomarkers for both diagnosis and prognosis of etiological differentiation of febrile patients, and their risk stratification and prognostic evaluation. His research has also covered the new paradigm of malaria eradication, and he has a particular interest in evaluating the role in elimination strategies. So thank you, Kike. I hand over to you.
Thank you very much. I'll try to be very concise. I know I only have 15 minutes, so the idea is to have a quick overview on the malaria situation. First, a disclaimer, I don't have any conflict of interest. And my only potential conflict is that in 1999, the day I finished medical school, I had an unsuccessful interview with MSF Barcelona. So not that I didn't try to work with you guys. So let's start with malaria WHO, and I deliberately chose the picture of a pregnant woman and a young child, both of them receiving a blood transfusion. Anemia in malaria is the #1 cause of malaria deaths globally. And those two are clearly the two most vulnerable population groups. And I'm going to focus today on children. And where is malaria transmitted? So this is a figure showing where malaria was transmitted 120 years ago in the 1900s at the beginning. Essentially, malaria was a global disease transmitted everywhere. And this is the situation of malaria today, where transmission has been shrunk between the tropics. And it has been made by the action of man a tropical disease. But just to remind everybody that it's not inherently a tropical disease. It's the action of man that has transformed this disease into a tropical one. This is the distribution of the two main species, falciparum and vivax, essentially identical except for sub-Saharan Africa, where there is very little vivax. Vivax requires a specific receptor in the membrane of the reticulocyte to invade the reticulocyte, and the majority of the African populations are DOFI negative of this receptor. Therefore, there is very little transmission of vivax among native African populations, but there is a little bit in the Horn of Africa, and that has also some importance. Numbers, Sisha, you've mentioned already numbers, 241 million cases of malaria in 85 countries in 2020, vast majority in the WHO's African region. The number of vivax cases has been revised and decreased and considered to be only about 2% of the global cases today. That's about 4.5 million. 627,000 deaths estimated to have occurred in 2020. Massive improvements since the early 2000s, but unfortunately a 12% increase since 2019. And I'll say a few words on that regarding the impact of COVID. 96% of all malaria deaths occurring in Africa. The countries that have been already mentioned, 4 countries accounting for more than 50% of all malaria deaths globally. And funny enough, you are treating about 1% of all malaria cases in the world. So you should be very, very proud as MSF. 77% of all malaria deaths occurring in children under the age of 5 in Africa. So essentially, malaria is a pediatric disease affecting mostly children in sub-Saharan Africa. And if we look at the overall causes of child mortality, or causes of under 5 deaths, malaria accounting for about 8% of the global deaths in children under the age of 5. If we were to look at this figure only for Africa, it would be around 20% of all African child deaths. And remember, this is the Africanization of the iceberg metaphor. We have quite good estimates on malaria morbidity and mortality, but as far as we know, we are only seeing the ears of the hippopotamus, or the tip of the iceberg, because many of those cases and many of those deaths are invisible to the health system, and they are occurring at the community level. And we need to remember this, because we need to reach the community if we want to have any impact in our malaria control activities. And what about malaria control? So essentially, there are 3 main strategies. The first one is to reduce the contact between humans and vectors, essentially the mosquitoes that transmit malaria. The second one is vector control to kill those mosquitoes. And the third one is the use of drugs or other preventive strategies like vaccines. And remember that when we use drugs, we can use them to treat the cases already established or to prevent future cases using pharmaceutical preventive strategies. What about a few of the numbers? Because we have unprecedented success and progress in the last 20 years. 2.3 billion bed nets distributed in Africa in the last 15 years. The number of children under 5 sleeping under bed nets has dramatically improved from less than 2% in the year 2000 to around 50% today. We have an additional 2.6% of the African population protected through indoor residual spraying, nearly 250 million ACTs delivered in 2020, more than 2 billion since the year 2010. And the rapid diagnostic tests, which are the democratization of the diagnosis of malaria, which have significantly improved the way we actually identify malaria cases. 2.2 billion malaria RDTs distributed in the last decade. So amazing progress. Amazing innovation also. Just the fact that we have rapid diagnostic tests, even if they do have some caveats, but we didn't have them about a decade ago. So we should be very proud that we have managed to bring the diagnosis of malaria, democratize it, and bring it to the community level. We have much better bed nets today that can last up to 5 years and don't need to be replaced. We have new families of insecticides, although this is a field in which there is much need for innovation. We have a much better drug today for the treatment of severe malaria. Artesunate is clearly superior to quinine, and we have had massive improvements in the treatment of severe malaria thanks to a better and more fast-acting drug. And of course, we have a malaria vaccine that I will briefly speak about. Important to mention the chemoprevention strategies, particularly targeting vulnerable groups. We have intermittent preventive treatment in pregnancy, which is IPTP, which have what it was formerly known as intermittent preventive treatment in infancy, now called perennial malaria chemoprevention. And of course, we have SMC, seasonal chemoprevention for children under 5 years of age. The combination of these 3 strategies, even if the central one is not massively deployed yet, has importantly contributed to a decrease in the numbers of potential new malaria cases. So this is something that we need to have very much in mind. And even though coverage rates can be improved, this is a substantial innovation and change in regards to what happened less than 10 years ago. And we also have the mass drug administrations, and there are several ways of actually treating entire communities with MDA. We can use it for burden reduction in emergency settings, to reduce transmission of Plasmodium falciparum in very low to low or moderate to high transmission settings, or also specifically targeting PV transmission settings. So other strategies very well explain how to use them in the field, in everyday life. The new WHO guidelines specify very much the cases scenarios, and MSF follows those guidelines typically to deploy them. Just some examples of the numbers. SMC, about 33 million children were treated in 2020 with SMC. This is an improvement of 12 additional million children treated, thanks to the expansion of the program to some areas of Nigeria. As you know, Nigeria is the epicenter of malaria of the world. So anything that you implement in Nigeria is bound to have massive impact in terms of reducing malaria morbidity and malaria disease, and malaria death, sorry. Intermittent preventive treatment in pregnancy, we were having significant improvements during the last 10 years. Of course, the pandemic hit hard and we've had some reductions, but the message here is that we have important space for improvement, because only 1 out of every 3 women are actually receiving the minimum of 3 doses during their pregnancy, which is the minimum recommendation of IPTP. And let me just mention very briefly the new WHO guidelines, because this is important because the previous recommendations had 3 major pain points. First, it was perceived as a very lengthy process to change any recommendation. There were some inconsistent recommendations that were not necessarily applicable to all settings, and there was a suboptimal use of WHO's malaria guidance at the country level. And those new recommendations, who were published in 2022 and have recently been updated a few days ago, address those inefficiencies and enable faster, more flexible, data-driven decision-making for national malaria programs. And they're considered living guidelines, because they allow the rapid and clear dissemination of new evidence through an app platform. They are flexible, so they can be adapted to local contexts, because we do recognize that one size does not fit all countries, and therefore all countries need to be sovereign on their capacity to interpret and adapt those guidelines that fit them better. And this, of course, gives some country ownership for a sustainable fight. Let me give you a few words on the malaria vaccines. This is a very hot topic this year. Let me just show the clinical development of the RTSS malaria vaccine, the only vaccine that we have available today and authorized for its use in malaria endemic areas. But just for you to get an idea, this is the malaria clinical development plan of this vaccine. It took more than 30 years to actually have a product registered and recommended. Just compare it to the red little line, in which during 6 months we had 4 COVID vaccines available to use in humans. So, and not because malaria is not a public health emergency, which was the rationale for running so fast with the COVID vaccines, but just because malaria is not affecting the entire world. And that has delayed unnecessarily the development of these vaccines. The first malaria vaccine implemented in real life was actually given on the 23rd of April 2019 in Malawi as part of this pilot project involving 3 countries, where 2.4 million doses were administered to nearly 830,000 children in Kenya, Malawi, and Ghana. And what we were able to see during this pilot project is that the administration of 4 doses of the RTSS malaria vaccine, including 1 after the first year of life, was feasible. It was equitable because it actually reached better than other malaria interventions like bed nets, the general population. And importantly, it had a massive impact because 1 life was saved for every 200 children vaccinated. There are not many interventions that can actually say that. 40% reduction in malaria episodes, substantial reduction in deadly severe malaria in routine use. So in 6th of October 2021, WHO endorsed its widespread use in sub-Saharan Africa. And the important and big news is that the field of malaria vaccine development is in good health. And we have new products, like, for example, the R21 vaccine that has shown 75% efficacy, not only in phase 2 trials, but more recently in phase 3 trials. We have excellent protection of the sporozoite-based vaccines in human volunteers. We have the prospect of an RNA-based malaria vaccine, mimicking what has been shown for COVID or for more recently for flu. We have excellent results of combining SMC with seasonal malaria vaccination, actually 70% increased protection over either intervention on its own. So malaria vaccine is not the magic bullet, but it dramatically improves the performance of other interventions if applied alongside. And we also have important developments in the field of monoclonal antibodies with very, very good results coming from field trials in volunteers first, and also in the field in adults in Mali. But unfortunately, we have many perils ahead. We have funding gaps. It is calculated that we need $3 billion, that we would need up to $10 billion per year until the year 2030 to actually eliminate malaria, and we are only spending about a third of that. We have massive coverage gaps, some of which have been mentioned. Only half of the children are actually sleeping under a bed net, those who are at risk. We still have about 60 million malaria cases which go undiagnosed and untreated. And more importantly, we have important biological challenges. Insecticide resistance, very few new insecticides in the pipeline. Drug resistance, a particular problem in the Mekong region in Southeast Asia, but more recently identified also de novo appearing in places in Africa like Rwanda or Uganda. And importantly, RDT resistance, or that's how I call it for easiness, which is the fact that some RDTs, some parasites do not express the protein detected by the RDT and therefore are invisible to that RDT. And therefore that patient which is tested is not identified as having malaria and can die as a result of not being treated. There is an excellent malaria threats map published by WHO, which I recommend you to actually look at, that exemplifies all of this. And let me finish with COVID-19 and malaria. Let me also stress that the house was already on fire before the pandemic. And in 2017 and 2018 World Malaria Reports, this was very clearly identified. There was a stagnation of progress. Malaria situation was thought to be at crossroads. And if we were not to improve that situation, the risk was that we could go backwards again. And we know how dangerous it is to go backwards with malaria. There was also a fear with the pandemic that the distribution of bed nets, which occurs on a 3-annual basis every 3 years, and which had 2020 as one of the years of big distribution of nets in the continent, was going to be massively hit by the pandemic. And it was like that, this occurred. And there were many other mechanisms by which malaria could worsen the malaria situation, because mostly of the indirect effects of the pandemic and the lockdowns and the restrictions of movement and the air lockdowns, by which it was very difficult to have many of the measures reach the population at need. The worst case scenario, and this is my last slide, was there were a set of scenarios planned, and the worst case scenario said that we could have up to 769,000 malaria deaths in African children, so more than double the deaths that were occurring. Fortunately, the number has been less, but there has been a 12% increase of malaria deaths, and up to 2/3 of those additional deaths are estimated to have occurred because of service disruptions. So a big problem, but fortunately not as big as we thought, and we are catching up with the situation. And let me finish 5 seconds in advance. Thank you very much.
Great. Thank you so much, Kike, for giving us that walkthrough of what is quite a complex area. And as you can see from that presentation, there are so many things that interconnect. And, you know, we're going to get into more of that in the discussion later. I did forget to say that at the moment, we will be responding to your questions during the Q&A part as part of our malaria roundtable. So please do hold on to that, and we will present the results of the online poll then for you as well. Now, it's my great pleasure to introduce 2 video presentations that will run back to back next. These are 2 really great initiatives by our field projects. So first of all, we have a video from MSF Spain. It's the team in Batangafo in the Central African Republic. They're going to be presenting their experience of implementing IPTI. We all know what that is now, and which is now referred to as perennial malaria chemoprevention. It's a project that was implemented this year. And also then we'll hear from MSF Switzerland, the team in Angumu, Ituri province in the Democratic Republic of Congo. They will be presenting on a mass campaign that includes IRS and anti-malaria drugs in a community setting with a highly endemic transmission of malaria. So I'll hand over then.
Le traitement préventif intermittent chez les nouveau-nés, les nourrissons, les TPIN, est un traitement anti-palydique déjà approuvé par l'OMS qui est administré en une dose unique pendant la première année de vie du nourrisson, au même moment que la vaccination de routine. Il a été très démontré que le TPIN réduit globalement, n'est-ce pas, le paludisme clinique chez les nourrissons à 30%, tout en réduisant également les autres formes graves du paludisme. Il est capable aussi d'éliminer toute infection existante, mais aussi de prévenir toute nouvelle infection. Quand on administre de cette manière-là le TPIN, il est très bien utilisé par même les agents de santé communautaire. Il est très facile à manipuler et aussi ça minimise le temps de consultation et protège contre le paludisme pendant une période d'environ 35 jours. Il faut noter que la transmission du paludisme en République centrafricaine est très élevée, très élevée, surtout pendant la période pluvieuse. Et les structures sanitaires sont tellement sollicitées et 80% d'enfants sont vus au niveau de l'hôpital de Batangafo. Ils ont un paludisme grave. Vous allez comprendre que les services sont trop sollicités pendant la période pluvieuse où il y a une forte transmission du paludisme pour toute la population, y compris les enfants de moins de 5 ans. Pour lutter contre cette maladie mortelle, MSF a mis en œuvre depuis longtemps des stratégies de prévention de paludisme chez les nouveau-nés à base de la sulfadoxine pyrimétamine. Et aussi, il faut noter que d'autres stratégies ont déjà été mises en œuvre dans nos structures sanitaires, notamment à Batangafo. Et nous considérons que vraiment le TPIN comme un fort ajout à ces paquets de services. À part cet EPIN qu'on venait de dire, il y a aussi la distribution des moustiquaires, la décentralisation des traitements au niveau communautaire. Il y a aussi les diagnostics et la prise en charge du paludisme au niveau communautaire que nous mettons toujours en œuvre pendant la période de haute transmission, surtout pendant la période des pluies.
Ce type de programme, généralement, répond à plusieurs étapes. La première étape consiste d'abord à définir la zone dans laquelle le programme va se tenir, et en l'occurrence ici, la zone pour ce genre de programme, c'est le service PEV qui est fonctionnel et qui parfois est appuyé par le partenaire MSF. Et pour ce qui est de la cible pour ce genre de programme, c'est généralement les enfants d'une année, enfin de moins d'une année. Mettre en œuvre ce programme-là doivent être formés. Alors pour pouvoir mieux tenir le programme, c'est-à-dire comment organiser, quelles sont les informations qu'ils doivent en fait recueillir pour à ce que le programme soit effectif. Donc ils doivent être, comment dire, formés pour renseigner les supports d'évaluation et aussi de suivi du programme. Pour conclure, je tiens juste à rappeler que c'est un programme qui vise beaucoup plus le côté préventif du paludisme. Mais il faudrait aussi noter que c'est un travail un peu laborieux parce que les mamans ont toujours tendance en fait à prendre en mal un peu les choses, et s'ils voient que peut-être leurs enfants réagissent aux médicaments, ils pensent que le programme n'est pas efficace. Alors que c'est juste question en fait, de comprendre que tous médicaments qui sont pris par les enfants, parfois ils peuvent réagir par des effets secondaires. Et donc la leçon à tirer, c'est beaucoup plus de mettre l'accent sur la sensibilisation, encore la sensibilisation.
MSF est présent dans la zone de santé d'Angoulou depuis 2019 et MSF prend en charge les populations autochtones et populations déplacées issues des atrocités et de l'insécurité des groupes armés présents. Nos principales activités sont la prise en charge des pathologies dans les centres de santé et également à l'hôpital de référence de Angoulou. La malaria est hautement endémique ici et s'étend sur toute l'année, ce qui constitue d'ailleurs la principale cause de consultation dans les centres de santé et à l'hôpital de référence. La prévention reposait uniquement sur la distribution de moustiquaires coordonnée par le ministère de la Santé et MSF. Et aujourd'hui, je peux dire depuis 2020-2021, nous avons essayé d'étendre nos activités de prévention avec la distribution massive de médicaments et de la pulvérisation intradomiciliaire qui connaît un grand succès en ce moment, qui nous a permis d'étendre nos activités au niveau de 10 aires de santé.
Les zones d'intervention ciblées pour la MDA sont les aires de santé proches du lac, sont les aires de santé qui hébergent des sites de déplacés. La zone est endémique parce que il y a eu d'abord la montée des eaux du lac, ce qui a favorisé les endroits stagnaques, qui est un endroit vraiment propice pour la multiplication des moustiques.
Et par rapport à cette activité de pulvérisation interdomiciliaire, nous avions collaboré avec le ministère de la Santé publique à travers le comité de santé et la cellule d'activité communautaire au niveau des villages. Le contrôle vectoriel vise à interrompre ou à perturber la transmission du paludisme et en limitant l'interaction entre les humains et les moustiques.
Oui, il existe plusieurs étapes pour arriver à réaliser cette activité. D'abord, il faut faire l'évaluation du nombre de maisons à pulvériser. Ça, on a fait appel à notre DIS à travers l'acquisition d'une image satellite, ce qui nous a permis d'avoir une idée sur le nombre de maisons pulvérisées et le nombre des insecticides dont on aura besoin pour faire cette activité. Ensuite, on a développé une application qui nous permet de faire le suivi de cette activité à distance. Nous avons effectivement collaboré avec le ministère de la Santé, ce qui nous a permis d'avoir 120 relais communautaires mis à notre disposition par le ministère de la Santé. Ils ont été formés comme des agents pulvérisateurs, c'est eux qui font les activités sur le terrain concrètement. Nous avons construit deux bases arrière qui comportent de vestiaires, de douches et autres, ce qui a permis de rassembler les équipes parce que les agents, une fois partis sur le terrain, ils viennent s'échanger ils doivent aussi se laver. C'est pourquoi nous avons conçu cette base arrière.
Le programme de promotion de la santé est indispensable car il nous permet d'assurer la mobilisation de la population pour atteindre un minimum de 80% des maisons à pulvériser. Et pour cela, il faut que les gens nous laissent entrer dans leur maison. Et l'HP passe pour informer la population par rapport à quand aura l'activité et pourquoi cette activité sera faite. Deux fois, il y a des refus à cause de mécontentement ou odeur du produit, mais quand nous arrivons à négocier avec eux, les gens acceptent facilement.
Le travail des entourements ici consiste à étudier les moustiques pour raison de suivi et de contrôle de la qualité des pulvérisations. La capture des moustiques, en fait, dans la communauté, nous déployons des pièges dans le but de surveiller la densité anophélienne et de voir s'il y a des possibles changements dans les espèces de moustiques qu'on a dans la zone. Grâce à nos différents tests, nous nous assurons que le moustique ne développe pas une résistance à l'insecticide, ce qui est aujourd'hui un problème aussi grave que la résistance aux antibiotiques.
Alors en fait, le contrôle vectoriel est essentiellement grâce aux moustiquaires imprégnés et à la pulvérisation intradomiciliaire aussi. Et la raison principale de la réduction des cas observés mondialement depuis le début des années 2000 pour la malaria. Par contre, chaque contexte est différent et nécessite une réponse adaptée. Que ce soit au niveau de la résistance aux insecticides, que ce soit dû aux habitudes humaines ou bien au comportement des moustiques. Donc chez MSF, c'est une décision qui est opérationnelle et qui implique tous les départements. Ça peut avoir un impact particulièrement fort et marqué sur la transmission. Et donc l'intérêt est de pouvoir réduire le fardeau de la malaria pour les populations. D'un point de vue pratique, ça veut aussi dire que les autorités nationales seront donc plus à même et pourront prendre en charge plus facilement leurs responsabilités, notamment de soins par rapport aux populations.
So thank you so much. Big thanks to the field, both fields, for really excellent quality presentations. And I think it was really interesting, particularly in the IRS presentation, where they really highlighted the importance of community engagement. We haven't discussed that so far in this session, but I want you to keep that in mind, maybe for later. It's my very great pleasure next to introduce our next speaker. He will be presenting a very nice video to explain some of the really interesting work that he's been involved in. So Dr. Paul Sondo, he's a medical parasitologist with a focus on malaria research. Following his PhD, he undertook some career development programs, including the esteemed EDCTP TDR, Clinical Research and Development Fellowship, and also the EDCTP Career Development Fellowship. So for those that don't know, the EDCTP is the European and Developing Countries Clinical Trials Partnership, and the TDR is a WHO-affiliated special program for research and training in tropical diseases. Over the last 5 years, Paul has been working on projects such as assessing the efficacy of antimalarial drugs and also investigating the genetic diversity of P. falciparum and its mechanism of resistance to various drugs. More recently, his work is focused on SMC through the implementation of two quite big projects, which included SMC NUT and SMC RST. And he's also been awarded the Institut Mérieux Young Investigator Awards in 2018. A very warm welcome to Dr. Sondo.
Bonjour, je suis Paul Sondo de l'Institut de recherche en sciences de la santé.
Good morning. I work at the Health Research Center in Burkina Faso. I will be presenting the research of the National Plan Against Malaria, and the Ministry of Health Nutrition Department study which focuses on the evaluation of a combined strategy of SMC with plumpidose and vitamin A zinc supplementation for the prevention of malaria in Burkina Faso. To D'abord, I'd like to remind you that malaria is a major public health issue. Prevention of malaria is a key component of the disease control strategies, and the means to prevent it are mainly focusing on long-acting impregnated mosquito nets, IRS, preventive treatment in pregnant women, and SMC, which is an intervention which aims at reducing the prevalence of malaria in children aged 3 to 59 months. This map shows the distribution of seasonal malaria in Africa. Most of the cases are found during the rainy season. In Burkina Faso, it's between July and November. So Burkina is an ideal setting to introduce SMC. This type of prevention measure involves a combination therapy given to children aged 3 to 59 months every month for 4 months, and or up to 5 months, depending on the rain levels. And between June, August, September, and October, we have SMS implemented. It helps to reduce the incidence of malaria by some 75%. But in spite of this strategy implemented in Burkina Faso since 2014, we still have a high burden due to malaria in children under 5. So we wondered whether there were some factors that had a negative impact on this intervention. And when you consider malnutrition, as you know, it is a major cause of child morbidity and mortality, because it weakens the immune systems and results in more severe forms of malaria in the general population, and also decrease the efficacy of the anti-malarial treatment. Even more than that, all the micronutrients deficiencies, when they are treated, are known to reduce the morbidity and mortality. So based on this, we have come up with an assumption which would be combining SMC plus micronutrients to help better reduce the burden of malaria and malnutrition in these children. And for that purpose, we have set as a primary objective evaluating whether SMC plus vitamin A plus zinc, that is, and also plus plumpidose and vitamin A would be more efficient to reduce the incidence of malaria while improving the health status of children, as opposed to the standard SMC. The secondary objective is to assess the impact of this strategy aimed at reducing the impact on children. Our methodology is the following. We have 3 arms. It's a randomized study which was carried out between July 2019 and June 2020 in the Nanoro Health District. In the first arm, plumpy dose was combined with SMC. The second arm is the control arm with no supplementation. And the third arm is the arm where zinc was added. There was a 12-month follow-up, 6 months of active monitoring, and 6 months of passive monitoring. And over 4 months, the plumpy dose was given. Plumpy dose is a ready-to-use therapeutic food which can be directly used at home without requiring any specific preparation. 1 pouch a day per child was given for 4 months during the SMC. And for zinc, each child was given 1 zinc tablet containing 10 milligrams of zinc 6 days per week for 4 months. That is the whole SMC period. So these are the results and our findings. In total, 1,059 children had been randomized with 3 arms, 353 children per arm. At the end of the follow-up period, we have had more than 97% of children in the plumpy dose arm, 95% of children in the control arm, and 96% of children in the third arm, that is zinc supplementation, which is quite an acceptable follow-up rate, which shows that the monitoring system did work rather well. Most of the children were sleeping under long-lasting and long-acting impregnated mosquito nets. That's 91% of them, which when the SMC started, the positive rate of 2 RDTs was 22%, and microscope studies showed 10% positive rate. Malnutrition prevalence was very high in these children at the beginning of the SMC. Stunting was also high, and there was also a low weight that is reflecting acute malnutrition. And the prevalence of malaria is already very high before starting the SMC campaign, suggesting a need for an early starting of SMC in the area. And also, when you consider the prevalence of malnutrition, most of children were malnourished during this period. So there is a need to promote a synergy type of intervention to control both malaria and malnutrition during this season in this area of sub-Saharan Africa. The impact of this intervention is shown here. We can see the impact of the supplement given on the incidence of morbidity for all causes and the reduction of severe malaria. The green line is the control, the red one is a zinc group, and the blue line is that of children who were given the plumpy dose. The first graph shows the morbidity for all causes throughout the follow-up period. Morbidity went down in those children who were given these nutrition complement. The graph in the middle shows the simple form of malaria incidence throughout the SMC period. And here again, those children who were given the supplement had fewer cases than in the control arm. Now, when it comes to severe malaria, those children who were given Plumpy in addition to the SMC have shown a significant reduction of severe malaria versus those who were given zinc or those of the control arm, control group. Now, we may conclude from these results that throughout the peak of the malaria season, many children with SMC treatment are also having malnutrition. Now, the feasibility of a strategy combining SMC plus micronutrient supplementation in sub-Saharan Africa is possible. This micronutrient would help further the impact of SMC to reduce further the morbidity related to malaria while improving the nutritional status of children. And this was even better when using RUTF such as Plumpy. I would like to thank all those who've helped us and worked in this study. I'd like to thank our partner, EDCTP, which has helped us to fund 100% of this study with the Caritative Fellowship Program. I also would like to thank the National Program to Control Malaria and the Nutrition Department of the Ministry of Health, and also NutriSet for providing the Plumpy for this study. And I would like to thank the local community and all those who've taken part in the study. And I'd like to thank the staff of this health area, and a great thank to Nanoro and the community health worker of Sao and Zoid for all their support. Thank you also to MSF for having given me the opportunity to present the result of this study along with the scientific community. Thank you to all of you for your attention. Thank you very much.
Hi, and thank you so much, Dr. Sondo, for presenting that very interesting research. I hope that we get a chance very shortly to have a discussion on that. You were able to introduce some of the challenges that we really see in field settings. Now, the next part of this session is going to be very interesting. I'm quite excited about this. We're going to a round table. So apart from Drs. Paul Sondo and Kike Bassa, who we already introduced, we have also invited Mitchell, Letizia, and Arnaud to join the roundtable discussion today. So Mitchell Sangma is a medical doctor from India with a postgraduate degree in international public health from the University of Queensland in Australia. He has worked with MSF since 2011. As a public health specialist, he has been involved in multifaceted health programs in complex humanitarian situations, everywhere from Uganda, Uzbekistan, Zimbabwe, Syria, Turkey, Jordan, South Sudan, Ethiopia, Nigeria, Bangladesh, and Myanmar. Yeah, it's quite impressive. And currently, as MSF's OCBA health advisor, he's based in Nairobi. Mitchell has been providing direct medical support to the complex field operations in South Sudan, Sudan, Somalia, and Ethiopia. Next, we also have Letizia Di Stefano. Thanks, Letty. She's a medical doctor and infectious diseases specialist, and she has started working for MSF all the way back in 2009. She's held many different roles also in MSF, firstly in operations as a field doctor and a medical coordinator in countries such as the Central African Republic, Guinea, and Pakistan, and also as deputy operations coordinator focusing on Nigeria, Mali, and Bangladesh, amongst others. She also previously worked in TB/HIV as an advisor and implementer in the Okbar Medical Department, and now is a referent for malaria and neglected tropical diseases in the Brussels headquarters for MSF, and very much focusing on malaria and neglected tropical diseases these recent times. And finally, last but not least, we have Arnaud Desjardins. We saw a little cameo in one of those videos of him there. You might recognize him. He's a former nurse with a background in emergency room and tropical diseases. Arnaud joined MSF OCG in 2016, MSF Swiss, and after a few missions, first as a nursing activity manager and then once as a project medical referent, he decided to return to his true passion, which is biology. After a master's at the Liverpool School of Tropical Medicine, where he dedicated time to biology, epidemiology, and the control of parasites and vectors, Arnaud then went to a field mission for vector control in Honduras in 2021 with MSF to prevent dengue fever. And he now works as a flying vector control for OCG, MSF Swiss, in order to really support the field in the practical implementations of vector control activities, like we saw in the Angumu video. So thanks so much and for joining, guys. I think we're going to have some really interesting discussions. I thought I'd open up with a first question. It's a bit more broad, but just considering we've been talking about a lot of different projects and settings, I wanted to pitch this one mostly to Mitch and Letizia at first to have that MSF input. What malaria interventions do you think should exist in all our projects?
Perhaps I can start. Well, first, warm greetings from Nairobi. And I think I must say that I was very inspired by seeing the videos from the field. But anyway, coming back to the discussion points, well, I think it's highlighted in the presentations that there is no one size fits all. I think when we talk about the projects, about all the projects are different, even in the same country, even in the same districts. So I think that's very important, like while looking at the intervention strategy, that we need to consider the important factors, especially in identifying the population at risk, identifying the most vulnerable group, and also acknowledging the presence of other actors and including the presence of factor control programs. And I think the most important point is also the security. You know, like in many of the MSF projects, we work in conflict-affected areas. So we also have to see the feasibility of what type of malaria interventions programs we can implement in certain settings. And of course, the context itself, whether it's a closed setting like IDP refugee camps or it's an open catchment populations. But when it comes to the very basic, like what we expect from the malaria interventions, I think, what we expect and what we should have in all the projects in MSF projects in malaria endemic area, I think number one is the access to the rapid diagnostic tests and essential drugs, availability of the simple fight protocols. And of course, it's a bonus when you have the access to the long-lasting insecticides, long-lasting mosquito net. And it's a double bonus, I would say, when you already have the community program in place. Now we are acknowledging the importance of community programs. And I think in the recent years, we have shown that, how it has been able to decentralize the programs at the community level. It was a long discussion and debate, I remember, in my younger days when we started rolling out the community programs, talking about how we can do that, how will we monitor the quality. But over the times, I believe that we have learned that it is possible. So the presence in the community, I believe, is a very important component. And also what you mentioned, Safshin, about the community engagement to get the feedback. So I think it's a very important aspect. So coming back to your core question, I think it's the drugs and it's the rapid diagnostic tools, which are the two core components, I would say, for any malaria interventions. But then the intervention strategy, it depends upon the project ambitions, about the external factors, and of course, the target populations. But often when there is a disparity, even within the same MSF project, when you talk about the different intervention, and some of them, of course, these are planning dependent or decision-making dependent.
Great, thanks so much, Mitch. Letizia, from your side, as a malaria referent, have you got things to add?
Yes, I fully agree with Mitch. And I think practically what we can do is indeed two very simple things. Mitch mentioned the distribution of mosquito nets, I think, during routine activities. And indeed, we have fantastic opportunities. For example, when we do discharge a child after hospitalization, or when we do perform antenatal care consultations. So these are very easy and feasible activities, but indeed we are providing an important preventative tool. And then, of course, the case management, I think, is the key, one among the key activities in all malaria strategy. And performing almost everywhere, I would say, medical consultation, I think, is quite a must to perform early diagnosis and treatment. And above all, as mentioned, also at the low level of care. So primary health care, but if we can indeed expand and scale up at community level, this would be an added great value.
Great, thanks so much. And I think this kind of follows on with some of the things we've already been discussing, but I wanted to throw this question out to Arnaud and Dr. Bassat. So if we really want to start thinking about how to implement some prevention activities in our projects, where do you guys normally start? What are the things that, you know, we should be assessing and considering before starting to make a strategy for our projects?
Arnaud, you want to go?
Yeah, okay, why not? I can start. Maybe one of the first thing we can do is already to check with other partners what is already planned. And because it's really, really usual that other NGO, other partner like UNHCR or that kind of people already have some project plan. And so one of the first things to do maybe could just assess what is already done or what is scheduled to be done in the next few days, months, and to create a collaboration between us and the other partner. That would be often one of the first things to do before to start to implement something or to spend a lot of resources on a project. I don't know if Kike want to add something.
I would agree with this, and I would also use opportunities which already exist and have good coverage. Expanded program of immunization as a way to access children under the age of 1, antenatal consultations as a way of reaching pregnant women. And particularly for MSF, which has a direct contact with hospitalizations in general, post-discharge, it's an excellent opportunity to also reach, as Leticia mentioned, for the distribution of bed nets, but also there is a recent wave of research looking at post-discharge prophylaxis for children with anemia, non-traumatic, non-hemorrhagic anemia, because it's been shown that if you give an antimalarial drug at the moment of discharge, you even if that person was not known to have malaria, you do actually decrease the subsequent risk of malaria and the outcomes in general. So using existing opportunities for direct contact with the population, because at the end it's always an access, or most of the time it's an access problem. When you are already guaranteeing that you will have a decent coverage, both from vaccination and from antenatal consultations, or when you know that the child is in contact with you because you have had that child hospitalized, those are opportunities that you cannot miss.
Yeah, great. Thanks so much, guys. And I think you've brought up some really key points there. This actually does lead us on to another question I was really keen to ask you. And I think I'm going to throw this one at Dr. Sondo and Kike, because it relates a lot to the kind of work that you guys do. If we want to actually combine efforts more efficiently, I mean, Kike just mentioned we have to use these existing opportunities, this opportunistic, administration of preventive activities that are integrated into something else. How can we actually do that in, for example, mass activities, or it can be quite challenging. And I think we need to think about how we can combine efforts more efficiently to tackle not only malaria, but things like malnutrition, measles in the community.
Prof. Sondo, s'il vous plaît.
Yes. Okay, thank you very much. This is an interesting question, how we can efficiently combine several interventions. That is, to me, the first thing is about accepting to work together, to work together. No one has a leadership in fighting any specific disease, and we should work together in order to efficiently implement joint intervention. And this starts by a political commitment, because in most of our Ministry of Health, we have a department for them. In Burkina Faso, we have the Direction of Nutrition, who intend to work separately from the National Malaria Control Program. And in such context, it's difficult to efficiently plan a joint intervention. So at the political level, we should set up an efficient system that allow the different directions to work together. And in such context, we can reach the groups in the field and better implement a joint intervention in the field. That is what I think we should start with.
And I would add that again, opportunities for synergy. The visits during the first year of life in infants for vaccination are the perfect example. We built IPTI, or what was formerly known as IPTI, around the visits for vaccination. That's why the first dose of SP was given at month 2, the second at month 3, and the third coinciding with the measles vaccine at month 9. Because the opportunities existed at that time, not because there was a predetermined plan to space intervention 1 and 2 with 1 month and the other one 7 months later. No. In EPI, you also distribute vitamin A for the prevention of the consequences of measles. So there are plenty of opportunities for synergy, and provided there is good safety of the mixing of interventions, always providing there's good safety, and of course you need research to show that, there often is synergies occurring between the two interventions. The recent example of adding the malaria RTSS vaccine with SMC shows that on their own, neither of the interventions, either RTSS or SMC on their own, is better than the combination. And it's not additive better, it's a multiplicative better. So there's always a need to look for those opportunities. And beyond that, there's also a need to assess what can be the added benefit of mixing interventions. For example, I will briefly mention ivermectin distribution in MDA for other neglected tropical diseases. We now know that ivermectin is effective at killing mosquitoes that bite somebody that has taken ivermectin. So could you have an additional added benefit in terms of interruption of malaria transmission when you are treating your entire population with ivermectin, not at the individual level, at the population level? So these kind of synergies and peripheral or beneficial additional effects need to be explored, because we will always win when we join forces, as Dr. Sondo was saying.
Yeah, and I'm so glad that you and Paul have brought these topics up, because particularly around this, integrating various interventions and finding the opportunities. And some of these things are so, in a way easy to do. We already have this child contact. We can quite easily give vitamin A. It's very compatible. And albendazole is another example. And it was really nice to have that example of the ivermectin and the transmission blocking. I think the next question, we should move to a bit more to talk about some of the challenges of implementing prevention activities in different settings. I'd like to pitch this one probably at Mitch and Arnaud to give us a few different perspectives on, if we're thinking about certain challenges of preventive activities, how different are the challenges when we're thinking about an emergency context, an IDP camp setting? Can you share a few reflections there for the team?
Sure. If I may, Harno. Well, I think it's a very good question when you talk about the barriers. And I think it's also the time for self-reflections. But here I must say that, of course, when you talk about the barriers, that there could be a different type of barriers. But perhaps for the sake of this discussion, I'd like to focus more on the internal barriers. Like as I was mentioning, like there are external barriers like related to the access because of the security, because of the distance, or there could be a barrier because of the cultural barriers or the uptake barriers for which we may need more anthropological approach, or we may need much more community engagement strategy. But these, of course, the solutions are very much context specific depending on the project locations. But when we talk about the internal barriers, of course, I think it's a good question. And but perhaps before I touch a little bit more on that, I think we can talk more about some of the good practices that we should also acknowledge. That yes, when we are looking at our project locations, like in most of the malaria endemic areas, I think there are certain levels of protections, activities or programs that we have already integrated, such as like what has been mentioned, like simple distribution of long-lasting insecticides for the pregnant woman coming to our clinic, or even integrating a very basic health education and health promotion messages, like especially with focus on personal protection measures and environmental hygiene. And I must say, like maybe just to give an example, like how I like talking about the mosquito net, like in my earlier days when I joined MSF as a young clinician, it's not that I'm old now, but in the field, I often faced the feedback, like from the field about the uptake of mosquito net, like how it was being misused, how they would use it for fishing or for any other reasons. But then 10 years down the line, now if I visit the project, I've seen a good acceptance from the community. And I think this has gone through like years of health education, engagement, promotions. And of course, it's a bit annoying to be bitten by a mosquito. So once you have that habit, you could easily follow the habits. So I believe there are already some good practices which are already happening. Also talking about the chemoprophylaxis, like how we're integrating into our ANC program, how into the pediatric program in some of the project. So I think we should also acknowledge that. But when you talk about the large-scale community program like SMC, like mass drug administrations, I think this is where we often face a bit of challenge in decision-making. First, number one, I think it's also to understand the objective of prevention program. Sometimes the objective could be just to show it as a pilot because it's a new program in that country. So we want to do it as a pilot and use the result to show that it works, and then use that for advocacy and for networking with the bigger donors. Just to give an example of South Sudan, we have done that. Yes, in 2020, we were the first one to pilot this SMC program in 10 villages, 12 villages, targeting around 10,000 children. We got a very good result, which shows that, yes, it decreases the episodes of malaria, decreases the severe malaria. But then it was just a one-time episode in 1 year, and then it stopped. So there was no continuity. So I mean, the real purpose here was to show that, yes, it works. Then, of course, when you talk about the context like South Sudan, where government is often already challenged with compelling priorities in terms of funding. So they cannot we cannot find the partners to continue with that. But when we talk about the large-scale community program for the purpose of prevention itself, like in the community, that sometimes, yes, it needs commitment, it needs motivations, it needs resources, dedicated resources, and of course, it needs budget. And like with the day-to-day work and activities in the project, sometimes we can be a bit myopic, not thinking outside of the box, especially during the planning phase. We tend to focus on the immediate gains or immediate program interventions. And sometimes we are a bit limited that some of the long-term prevention program, it also needs multi-year planning. But sometimes the scope of our MSF planning cycle, sometimes it limits that we just look at the 1 year planning. So I think those are some of the factors. And of course, there's also the high turnover of the managerial positions who make the decisions, and which can also have an influence on the current ambitions and looking at the preventions. So I believe that there are lots of reasons, like even within the organizations, that yes, but I hope that such events like this Pediatric Day will continue to inspire us to think outside of the box, especially during the planning phase. So I believe that engagement, continued discussions are important, and of course, but yes, in the end, it's all comes back to the project or the mission-specific decisions.
Yeah, great. And I know, have you got some reflections on the sort of closed and emergency setting, some of these challenges and how you manage those?
I will continue also on what Mitch was telling us. I fully agree because you cover pretty well the challenge we can face when we want to implement some activities. But most of the time, one of the main challenges is just also that people don't know what are the tools available to prevent malaria in the different contexts or the different setting where we are doing our intervention. And that is also something that will prevent to implement something efficient. Main challenge, as you say also, and I really want to insist on that, is the planification. When you want to do your intervention and the time you need to prepare the intervention, you need the supply, you need the human resources, you need to conceive a whole project, and that can be really, really challenging. So that is also one of the main challenge. And the last one I wanted to highlight also is most of the time is what exactly you want to achieve. What is your context? And so what do you want to do? Do you want to just protect your population? You just want to do some prevention? You want to control, to decrease the transmission, or you want to eventually eradicate the transmission, let's say, at least locally? So everything, it's something you have to consider when you want to implement that kind of prevention program. And it's not always easy, but we are here for that and to support people on that. So according of what you want to do will depend on the context. So I will go back to the emergency setting. Finally, each context is very different. So yes, unstable context or emergency context, you can do a lot of things. What you have to decide about the scale of the context. It's possible to do some remote prevention program, but it's quite complicated. So you have to prepare it even better than other program. And in refugee camp, you have a lot of to do also. You have to ensure, as you said before, we have basic requirements. Every patient have to sleep on and to be protected by a mosquito net. You have to ensure that the mosquito net distribution, even if it's done by other partner, it's properly done, because as Mitch said, you can have some misuse, but finally not that much. But the problem is the retention at the end of the distribution can be very different of the initial target. So all these programs have to be really considered and to be, let's say, carefully prepared. And but you can do a lot of things, whatever it's emergency, chronic program, or unstable. There is a lot to do, and we can do very efficient intervention.
Okay, great. Thanks so much. Yeah. I'd like to ask you guys now, because you were talking about how there's so many things that we can do, and you've given quite a number of different examples of different things that we can kind of consider to implement. But I wanted to see with Dr. Kike and Dr. Paul Sondo, can you maybe share with us some of the most interesting or innovative combinations of interventions that you've seen in projects, tailored to a specific place, and then how did they go?
Yes, maybe if I may start this time, I can think of practical examples of interventions that people don't think are important and are critical. For example, during the Ebola outbreak in 2014, the big epidemic in the 3 countries, the mass drug administration of anti-malarial drugs saved many more lives than the actual prevention measures of Ebola. Or in other words, malaria was causing many more deaths than Ebola itself, even though all the focus was put on Ebola. Similarly, mass drug administration in northern Mozambique during the big floods and the typhoons that occurred a couple of years ago was an essential maneuver to actually decrease malaria morbidity in the north of the country in a context of humanitarian or climatic crisis. No, so sometimes interventions that are not meant to be and are decided ad hoc because of the specific problematic of that moment end up saving many lives and end up having a massive impact. And I could think of this as a good example. And perhaps as a second example of combination of interventions, this is more in the innovation pipeline, not yet a formal recommendation, but for example, the addition of azithromycin to IPTI, to intermittent preventive treatment in the youngest, knowing the results of the Mordor trial in which azithromycin was shown to decrease child mortality when administered massively to a given population, that could be a big addition, no? And act synergistically to the impact that already IPTI causes, no? So thinking about interventions of things, even though sometimes they come from different fields, no? Azithromycin was an intervention given for trachoma initially, then showed this decrease in child mortality when administered as MDA to children. And IPTI is a malaria-specific intervention, but combining the two things together, why not? And this, of course, is currently being tested. It needs to be tested, again, as I said before, to guarantee the safety and to measure the potential additional impact before it becomes a recommendation. But these are the kind of synergies that we are so desperate in need for, and that could make a big change.
Yes, to add something to what Professor Kike has just said is the perfect synergetic intervention between malnutrition and malaria. And if in Burkina Faso, for example, vitamin A supplementation is also adopted as a national-wide intervention and during SMC round, there is a screening for malnutrition, and it's a perfect marriage. The intervention against malnutrition and malaria is a perfect, I can call it marriage, because it's applied to the same population, specifically children under 5 years. The second example of a synergetic intervention is that I would also like to mention is the combination of IPT during the antenatal care, and it's worked perfectly for as well as for child and for mother's health, and it also works very well. And in this line, we are implementing now a project who is using SMC intervention to improve antenatal care, or called an integration project. We will try doing SMC to see whether we can increase and sensitize pregnant women in the families in order to increase adherence to attendance to health facilities for antenatal care.
Thanks so much. And I really like this concept of sort of, thinking about interventions from even different disciplines. And I think that's a really important take-home point. I wanted to move on to something, maybe this is, I'd be really interested to hear about what Arnaud's pitch is on this one, and probably also Mitch from an operations point of view. We're seeing some current impacts of climate change on many diseases, including on malaria and the burden. For example, with more extreme weather events, there's more flooding, more displacement of populations, potentially to higher transmission settings. What things should our teams be thinking about when dealing with these types of issues? And are there particular measures of prevention or adaptation that you think we need to have like a climate hat on when analysing these types of contexts?
Arnaud, you want to go first this time?
After you, please.
Okay. All right. Yes, unfortunately, I think we're already seeing the first-hand impact of the extreme climate change in many of our mission locations, especially in the Horn of Africa. like the current drought that we are seeing now, which has been described, like current drought in Somalia, part of Ethiopia in Kenya, which has been described as the worst in the last 70 years with the consecutive failure of the 4 rainy seasons. While on the other contexts, such as in South Sudan, we are seeing the extreme of floods, with the extended rainy seasons, right, in the last 2 or 3 years, and now, which has been causing a massive displacement, especially during the rainy season. So I think we're already seeing the impact of the climate change has, I think, attributed to the extreme climate changes. And of course, I think like with these changes, I think it's very important that we start monitoring the epitrend, looking at our the malaria burden or the other disease burden, how it changes with what we are seeing now in the recent years. I think this monitoring, analysis, and reflections is very important to see whether what impact it has, especially in terms of the caseload. For instance, like yes, in South Sudan, especially with the heavy rain, we are seeing the flushing of the breeding places. So in the beginning of the heavy rain, we are seeing a decreased reduction in the malaria caseload. But then again, the malaria season is extended. So then again, when you look at the total number of malaria, it's still is more higher than compared to the last year. And where the context that in South Sudan, we are seeing the reduction in the malaria cases, but we also see now the starting of the like other outbreaks like dengue, chikungunya, and other diseases. So I think we need to have that. I think the understanding part and like how it is impacting, especially with the disease burden with the current changes. And I would also like to add that the entomological surveillance would also be very important if we have that capacity, like especially to understand like the change in the transmission rate. So I believe like having the understanding of the context or understanding of the change in the recent event, it's very important. Perhaps just to give an example, like in South Sudan, like we have been expecting the flood every year. So, and of course that was creating a difficulty for the patients from the community to come to MSF hospital. So now we started decentralizing more and more, like what we in MSF Spain, we call it decentralization model of care, or I think like it's an ICCM strategy that we started decentralizing, started pre-positioning more malaria drugs at the community level, like especially during the malaria season. And we also know that especially for the very severe cases, like we still need to get to the hospital, the access has been very difficult. So now for next year, we started planning to put on some local canoe, like the local boat, like give to the community itself so that they can arrange and they can coordinate and they can come with the support of MSF donated local boat to the hospital. So I think these are some of the measures, just to give an example of how we need to take into considerations the recent changes that we are seeing and how we can put certain measures, simple measures in most of the cases, but that can make a difference. And just also to highlight, like talking about the impact of climate change and of course the impact on the displacement, the massive displacement, like what we are seeing in Somalia. It's an emergency situation, and every emergency situation is very challenging. Like Arnold has already mentioned a bit about difficulty of getting the supplies in, the HR gaps, especially in the new context where we don't have the team there. Then it's like, or when there is no scope of hiring the local professional staff, and yes, flying in the international staff, it often takes time, or even the hiring the local recruitment at the project or at the emergency site, it's also very difficult. And also during the emergency, there's compelling priorities, like like there's a very need to set up the very basic food, shelter, water, safe drinking water, sanitations. So there are compelling priorities, and often when we look at the prevention program, it often takes a little bit of backstage, because the focus is on life-saving emergency interventions. But here, I just like to mention that, yes, in some of the projects, we have been trying to integrate already, like within the existing life-saving interventions, that some component of preventive programs, like distributions of a mosquito net. I think it's a good example where we're already integrating that into our existing programs. So, I mean, just to bottom line, I think it's like when we talk about the impact of climate change, it's there. So, but we need to adapt, we need to change. But for that, we need to have an overview of what's happening. And second is, I think, when I talk about the emergency, I think it's more about pre-positioning and preparing ourselves. That means like what we call it emergency preparations, expecting that what is coming, especially on the given trend, on the indicators of those changes. Thank you.
Okay, I will not add a lot of things because you already once again pretty well the topic. No, we already face the consequences of the climate change. So, but it's not only the climate change; it's also it's a side effect or the reason of the climate change. Means very wild urbanization, increasing in density population that will increase the contact between the vector, the pathogen, and the population. So we are just creating more and more contexts where you can have very severe outbreaks, and that can be a real issue for the next few years. Climate change will also create new endemic area because you will have new area favorable to the vector, to the pathogen also, when in some other area, locally, vector and pathogen will not fit. But as you said before, now we have also to face people who are displaced by climatic change, flooding or kind of thing like that. And that means you also have change in population, where you can see non-immune population seeking refuge in endemic malaria place, for example, that can lead to also, one again, a severe outbreak. And so all this change of population, it's something we have to be prepared. Another thing that we already know is, for example, invasive species, invasive vector for malaria. And one is specifically very worrying. And it's a vector who has the possibility to change the malaria profile, especially in Africa, where malaria was supposed to be more a rural disease. And now with this vector, we have to expect malaria outbreak in urban context. And that is something for coordination, for example, for MSF, where we have to be attentive about that, and we have to be prepared about it. So, voilà, it's epidemiology will be key. And I wanted just also to add something I forgot to add before. Community engagement is absolutely crucial. We didn't have time to detail that much, but it's really, really something important. We can't do anything without the community and the support of them. So just think about it.
Thanks so much. Now we're going to move on to we've been seeing some amazing questions come up in the Q&A. So thank you to everybody that's been putting the questions in there. As per usual, I don't think we'll get time to go through all of them, but yes, we will attempt to triage the most important ones, or the ones that most people liked. I'm going to throw this one at Letizia. All of these preventive activities require a good engagement from the community or parents. So some people in the audience would like to know, what is the advice on how to assure and work on that really well? Because there seems to be this impression that maybe we keep failing on this aspect.
Thank you for the question. That is indeed a key point. Indeed, we have quite extensive, let's say, health promotion activities, but the point is this enough? So maybe a reflection is, when we plan an intervention, should we actively involve members of the community, maybe in our planning? Should we ask first their opinion, and then work with them all together? Because indeed, if we want to reach a high coverage, we cannot reach without the community. And our intervention has also to be explained why we do the intervention, because the added value has to be fully understood. We are maybe providing some drugs to children, or we are spraying the houses. So it's not so obvious to let people enter in your house if the benefit is not so clear. So my suggestion would be really to include the community from the beginning and work with them in the activity.
Yeah, great points. Next question. This one's more about sort of the multiplication of various strategies for malaria prevention and control. We have someone in the audience who's wondering, considering that WHO guidelines extend these prevention recommendations to more countries, let's take, for example, SMC, which seems to be extending to more and more countries, will it be possible to implement all of these things in the WHO guideline? And more importantly, what are you seeing for the future? I'll probably invite Letizia to answer that one with Kike.
Yeah, I think indeed the new WHO guidelines are giving more flexibility indeed, because probably before they were a little bit too strict as rule to be fully implemented in the field reality. However, I think the main message is always to look at the local context and to look at the epidemiological profile in order to choose the best preventative package. Not everything can be put together, let's say, but for example, seasonal and perennial transmission for the different SMC can be indeed applied in seasonal transmission. However, different maybe IRS and chemoprophylaxis, or so integration of different preventative package, that's a key point. But I would always look at the local profile in order to tailor the intervention. Maybe Kike has more input on this.
No, it's exactly what you say, and it's providing the National Malaria Control Program some ownership on the decisions of what is taken. Very quick example is IPTI, which is a formal recommendation since 2010, but because it has the caveat of saying if there are more than 50% quadruple mutations in the SP resistance marker, you shouldn't use it, because nobody looks at this at a national level, nobody implements this. So if you have rules, as in the past, which are so stringent that forbid their formal application, then there is no way to move these things forward. And the current new guidelines, what they offer is this degree of flexibility for national malaria control programs to decide what they want to use, how they want to combine it, and how best to approach their specific malaria problem within their borders.
Thanks so much. Now, we are running a bit out of time. We'll aim to attempt to answer the other questions that we'll put in the Q&A. Some of them may have actually been answered over the course of this session, but we'll aim to do them by in the Q&A box. So apologies for anyone that didn't have their question answered, but they were all great questions. Next, we promised that we would give you the answers to that online poll. So I'm hoping that we can show that to you on the screen. And then just to recap, so the first question was, how many cases of malaria did MSF treat in 2021? So the correct answer was between 2.5 to 3 million, which is quite enormous, isn't it? Now, the second question, what does the term IPTI stand for? I think everyone probably knows that by now. We've discussed it a lot over the course of this session. So it's intermittent preventive treatment in infants. So it's the last option. And finally, the third question, which had an answer to it, was how often can you wash a mosquito net? Is it each month, anytime I need to because it's dirty, or never? So it's the middle answer. So it's anytime you need to because it's dirty. Just the usual hygiene rules. And yeah, the final question, as we mentioned before, there's no correct answer. It was just to have a bit of an understanding about what you have. So just very rapidly before I hand over to Joanna, I was taking a few notes for the wrap up, but yeah, I think I'll start with in terms of malaria interventions, what we should be thinking about in our project. So some of the key points are look at your target population. Also ensure that the basics are done and that they're done well, and they're done at the community level. So access to RDTs and ACTs. We might not be able to do complex community community activities if the security context is unsuitable. So you have to look at security for your teams, but ensuring the basics and doing it well, and also integrating epidemiology. In terms of prevention, what should we do when we're actually starting an actual strategy, and how we can use existing opportunities to integrate? We had so many great examples. We had, integrating malaria control into EPI clinics, ANC. We heard about post-discharge nets and even the new innovation of post-discharge prophylaxis. We've also heard about the importance of not only community engagement for any of these preventive activities, but also at the very other level is having this higher level political engagement, working with our Ministry of Health colleagues and, really ensuring that our strategies are working in synergy and not in silo. For the challenging settings in emergency context, this was one of the questions that came up in the Q&A, so hopefully this answers it. Just to recap, but we heard about how one of the most important things is to really acknowledge the good things that are working in the project and continue them, but also if you're wanting to introduce something new, do a pilot, look at your epidemiology, look at where there's gaps. There might be gaps in other activities that are done by other actors. And then also really tailoring it to the local context. And then in terms of innovations, we heard about mass drug administrations in Ebola, in flooding, and these are ad hoc interventions. And then also using that opportunity at any chance we can with any child health intervention to give them vitamin A, albendazole, give them catch-up vaccines. And this beautiful term, I'll end with this. This is Dr. Paul Sondo's words, that malaria and nutrition are the perfect marriage. So I want to thank all of the participants today. I want to thank all of the participants for being so great today and having this really wonderful discussion, and for all the amazing questions in the chat. Okay, I'll hand over to Joanna.
Thank you very much, Sashveen, for facilitating such a fantastic, fascinating and multifaceted session, and so great to hear from so many different perspectives, combining the latest in research and development, vector control, representatives from our operations department and medical department, and of course our frontline teams in the field. And I think your summary really, it applies to so many of our issues, looking at our target population, getting our basics right, looking at our epidemiology, and maximising our interventions with every contact with our patient. So thank you. I'm sure there are many, many more questions and a lot more discussion that could be had, but the malaria panel will be available during our conversations over coffee break for all your questions.